And just to jump into my presentation, I think that we are going to move from the interesting world of predictions to the world of observations and to the world of measurements. That is what we want to observe in our patients. Saying this, I want to emphasize that I'm a big fan of prediction models, and I think that these two points of view are not mutually exclusive, but just the contrary. The more information we can get, the better we will provide to our patients with anesthetic care. So I think that to start speaking about the depth of anesthesia, it would be better to set up some definition of what we consider depth of anesthesia. And if we have heard the previous speakers and we know from our clinical daily work what we do, we probably would agree in that what we do is induce some state of anesthesia, which is the combination of pharmacologic effects. Probably the most important are hypnosis to induce unconsciousness in our general anesthesia, analgesia to prevent pain, and nociception to reach the nervous system of the patient, and immobility because our surgeons and the patient and the procedure requires immobility to be done. Immobility, we could get it just because our hypnosis and analgesia are well combined with respect to the noxious stimulation, or we might need to add specific drugs as the neuromuscular blocking agents. And we need to preserve the homeostasis, the equilibrium of the body to help the patient to go through the surgical process with the minimum consequences due to the surgery and to our intervention. This goes in good agreement with what is called the hierarchical model of anesthetic state, which in essence sets up some stairways mode from the application of a surgical trauma towards the repercussion that this can have in the brain of the patient, and how with different drugs acting at different levels we can prevent this sensation of nociception going up to the brain. Quantifying anesthetic state, and my presentation will try to deal with the effect of hypnotic drugs and also to the way of trying to measure analgesia and the effect of nociception into the human body, and how both components might potentiate each other by means of the interaction of drugs that we have seen in previous presentations that have been studied and represented with these response surface models. Hypnosis is well defined and well measured at all levels with the EEG, especially with different mathematical approaches to the analysis of the EEG signal that usually comes synthesized in one value that contains and retains all the information that is relevant only to hypnosis, to the effect of hypnotic drugs, to unconsciousness, sedation, or whatever the measure of hypnosis we want to look at. And also, we can incorporate this information through the prediction models that have been mentioned before, specifically the NSRI index of anesthetic state. For analgesia, we have the classical signs of anesthesia, namely movement in response to some skin incision or some aggressive stimulation, changes in pupil size, sweating, tearing of the patient towards in response to some stimuli, the look to hemodynamic changes in response to a skin incision or to laryngoscopy. There are also possibilities of measuring the response of the autonomous nervous system, and there are some devices available that get track of the variability of in the heart beats and the level of respiratory sinus arrhythmia as a reflection of how the stress acts on the autonomous nervous system. And again, we can use predictions based in drug concentrations to analyze the level of analgesia that we induce in our patients. And also, as I will try to show in my presentation, we can use, have been attempts to use the EEG as a measure of analgesic level as well. The hypnotic component is based, and I think that nowadays is current use in most of the ORs all over the world, in the analysis of the EEG signal coming usually from frontal sensors that are placed in the frontal area of the skull. So the EEG is a good measure in the sense that provides us with information of what's going on in the cortical area of the brain. So we must have it clear. It's the brain, but it's just the cortex where it's reflected in the changes in the waves of the EEG. So it can be considered like a surrogate measure instead of a direct measure. Surrogate measure because it's a reflection of effects of anesthetic drugs that are going on at all levels in the central nervous system. The nice thing is that it's non-invasive, it's continuous, it's consistent across different patients. It has been shown from the early 30s that it's sensitive to the effect of anesthetic drugs. And the nice thing, as opposed to predictions in this case, is that it reflects individual response. So what the prediction of effect site concentration is really doing in that particular patient. The downside is that to understand EEG is not easy. It's not an intuitive signal. We have the heart rate, and we know that this means how the heart is beating per minute and so on, but there's no such a thing as the brain beat or the brain rate, because the brain works differently and the waves coming from the brain are hard to understand. It's a very small signal that it's susceptible to be contaminated with noise, with artifacts. It depends on where we put the electrodes. We can have a slightly different pattern of waves, and it's complex in the sense that changes in the EEG are multidimensional. You can see for the same drug that there are changes in one frequency band and at the same time in different ones too. So this is the picture that we can get out of the EEG, and this is taken from one of the more seminal works on the EEG in the year 1937, and we can see how the waves are changing as a result of the effect of the administration of a barbiturate drug. So are changes that even they tend to be slow and higher in frequency, the waves, it's hard to interpret what's really going on. And it's even hard to interpret also if we look at the spectral result of, for instance, a combination of propofol and remifentanil given. We see that it's not easy to get anything out of this image, and we need to reprocess all this information into something that easily can get to our information. So the goal is to extract from the complexity of the EEG the information relevant only to drug effects. And this is a general approach to the analysis of the EEG. From the raw, we apply different analysis methods. We get the processed EEG, and from there we extract parameters. Given the amount of analysis methods and the amount of mathematical approaches to this signal, we can even come with one different indicator of effect every day if we want. There are many, many, many indicators of drug effect based in the analysis of the EEG. But the key point is not how many parameters are there, but how these parameters really reflect what goes on in the patient. So clinical validation is the key step, is the cornerstone, and we need to look for what every parameter has demonstrated that it does in the benefit of taking good care of our patients. So clinical validation is really the important step here. And it's important because the EEG give us a reflection of how the patient reacts to this particular amount of drug. We can give 1 mg or 100 milligrams of propofol and whatever, and we will observe that most of the patients behave the same, but there are always patients that, because of their specific conditions, might react differently and might show a very intense effect from the same dose or very little intensity of effect for that particular dose. And this is what it's called inter-individual variability. The EEG has given us a new perspective in anesthesia quantification and has allowed us to overcome this inter-individual variability. Now we have these devices available in the OR for maybe almost 20 years, and we have learned as a specialist in anesthesia to get this part of the information and adapt the way we do our anesthesia to the specific responses that we observe in a particular patient. It allows us to look at the hypnotic effect and indirectly, as we will see in some slides, to get an insight also on how the noxious stimulation is influencing the patient. It helps us in personalizing anesthetic drugs, not only to the characteristics of the patient, but also to the kind of surgical procedure or endoscopy procedure or whatever the procedure the patient is going on in. And also it has given us some approach and has allowed us to learn how to look beyond what's going on in the operating room. And there's a number of papers relating the way we control anesthesia with the outcomes of the patients. And there's also a large number of publications and work that has been done into using the EEG in anesthesia as a neuroscientific tool to learn how the brain and the central nervous system works based on the response of our patients to anesthetic drugs. The analgesic component is a little more harder to interpret using the EEG, although there have been some attempts. And we need to keep in mind that to do a good study of this component of general anesthesia, we need to keep in mind that it should reflect the effect of the drugs we use for analgesia, and also it should be able to reflect the effect of noxious stimulation and how to balance both things with the use of drugs in the management of our patients. We all know that opioids act on the central nervous system. There's the endogenous opioid system that alters also some neurotransmitters in the way the central nervous system works. And there's a very nice review published by Emery Brown, an anesthesiologist that works a lot in neuroscience, in the year 2011, and I recommend it to anybody interested in this topic. And I'm sure that you will see in this slide how intense the changes that the opioids induce in the EEG can be. On the top tracing, there's the EEG coming from a patient who is lying still with no stimulation, no drug given. And if you administer a powerful opioid like remifentanil, fentanyl, or whatever, you will see how progressively the waves are tending to go slower and higher in amplitude. This is what it's called the delta wave pattern, and it's very characteristic of the opioids, and it doesn't go beyond that. Whereas if you give an hypnotic like propofol, you will have a continuous pattern of change towards a slowing of the EEG that ultimately will get into what it's called suppression, isoelectricity, or suppression with some bursts of fast activity in the EEG. So it's clear that the opioids can also alter the EEG tracing. And on that topic, there has been a lot of work done, even in the late 80s, and I must acknowledge here all the work done by one of my mentors, Don Stansky, and also Steve Schaefer's group at Stanford, where they demonstrated that using the EEG as a measure of opioid effect was the way to fingerprint the characteristics of each opioid, the onset, the offset of effect, and allow to build the PK/PD models that now we use, for instance, in the TCI systems that we can use clinically. Those are two publications related to this topic. And this is also how fingerprinting allowed us to see the power or the potency of sufentanil as the most powerful of the opioids that we have now available, as with respect to fentanyl, remifentanil, and alfentanil, and to get an insight on how should we dose these drugs to get the analgesic effect that we need. I said that it's important also to look not only at drug concentrations, but also to noxious stimulation. And in this slide, we can see how surgical stimulation generates some effect, and to get the same with the same drug desflurane effect site concentration, when the patient is stimulated surgically, the value of the bispectral index in this case goes up beyond. So it means that to maintain this same level of wellness for the patient, when there's surgical stimulation, we might need to increase the dose of desflurane. So it reflects, as in this case, in this slide, where we show the relation, the surface relating propofol and remifentanil towards the bispectral index. Also, we can see how increasing propofol plus remifentanil in a synergistic manner will generate a deeper value of the Bs, meaning a more intense anesthetic state or hypnotic state, whereas when the patient, in this case it was an endoscopy patient, has the endoscopy tube inside, the levels caused by this noxious stimulation on the Bs increase this value of the Bs at the same concentration. So it's required an increase of drug administration to get into the same levels of bispectral index. So it's important, and the EEG might reflect the opioid effects. Like in this case, it might look funny that given as I am a person who is supposed to look for adequate anesthesia and adequate effects, when I gave this bolus of propofol to a patient and then tried to do intubation, probably because I gave not enough analgesia, or I didn't wait enough to get the actual the levels of analgesia in the right place, we could observe this arousal of the EEG, that it was due to this insufficient analgesia. So we can see also traces of noxious stimulation not adequately treated when we look at the bispectral index or any other hypnotic EEG-derived parameters. So the opioids act on the brain, and we have seen that they generate these powerful delta waves that are really evident. The effect of opioids is apparent, and it should be quantifiable in the EEG, because the peak, and we have done this for PK/PD models, and noxious stimulation affects the EEG, and we have seen it in these two slides, which were with inhalation agents and the combination of propofol and opioids. But there's a problem, and the problem is that these EEG changes for opioids are produced at a range of concentrations that are clinically relevant for propofol when we measure propofol effects on the EEG, but are too high for opioids. So this slowing pattern of the EEG are at concentrations that usually are well beyond what we use in regular anesthesia and might fit better in what is used in cardiac anesthesia or so. And the changes on processed EEG that are due to opioids are usually overshadowed by the changes that are induced by the hypnotics. And this prevents us to get a clear information about opioid effect just by looking at any processed EEG parameter that we have seen. There has been, though, attempts to look at ways to extract information related to nociception from the EEG. And in this case, the Composite Variability Index, it's a combination of changes in the EMG electromyographic activity that can be picked up also by the EEG monitors, and the standard deviation of the bispectral index combined. But the studies that have been published so far are not really conclusive, and they give us very low ability to predict movement responses or even to correlate with analgesic drug concentrations. This was a work by the group of von Dinklage, and this other table comes from work published in 2013 by Ellerman, and we obtained here a better prediction with respect to movement, although not as good with respect when it wants to correlate with the predicted concentrations of remifentanil. And more recently, actually from this year, work done by the group of Michel Strois and by Sahinovic demonstrates that even though the CBI correlates a little bit or is better than other indicators, other indirect indicators of analgesic response, it's not really perfect, and it's really influenced a lot by the hypnotic state as measured by the bees. And this is what I want to demonstrate you here in these two cases that we collected in our department. You can see that when the anesthesia is kept in, let's say, relatively not very deep levels with a bispectral index oscillating between 55 and 60, then you can pick up some peaks of probably stimulation to the patient. Whereas when the anesthesia is much deeper and the bispectral index goes around 40 or even below, you cannot detect almost any change on the CBI, which to some extent correlates with what the group of Strois commented in the publication I showed you before. Recently, and I have been involved somehow in the clinical development of this QNOX indicator. The QNOX comes from the raw EEG, and using an adaptive neurofuzzy inference system, picks up different frequency bands of the spectrum of the EEG, trying to be optimized to predict movement response. And as you can see here, there were strong differences in the values of the QNOX from those patients that didn't move in response to either laryngoscopy, intubation, or placement of a laryngeal mask, as compared to the values that were observed in these patients that move. The QNOX also seems to correlate to opioid predicted concentrations, and by now it has been shown a relation of the probability of response to movement in both situations of sedation and analgesia, or TIVA for general anesthesia. But this is still under development. You can see here the curves of values of QNOX to the probability of response to these different stimulation
Pedro,
levels.
may I ask you to come to your conclusions, please?
Sure. There are other, and in sake of the time, I will not be able to go in deep detail, especially derived from the autonomous nervous system, multi-parameter indicators that have gone through different variations and that have shown promising results, but have never gone into really deep clinical intense use. The anesthesia nociception index has been introduced very recently. It's also under development, and it's based on the analysis of heart rate variability as a reflection of parasympathetic activity, and it has shown that predicts hemodynamic responses, decrease postoperative pain when it's used in perioperative, and it shows a better titration of opioids. So, to conclude, I would say that processed EEG indicators are the best for measuring hypnotic effect, the best we have right now. The EEG, as an indicator of nociception, correlates with analgesic concentration, might differentiate noxious stimulation, but hypnotic effect sweeps all other observations right now. And clinically, what we have right now, it's a prediction ability that it's not really optimal, and promising combinations of different indicators have not really succeeded. There are non-EEG derived, and I have shown very briefly, and they have limitations, and they have the ability to predict hemodynamic responses, but they are not perfect either. And for the future, probably indicators combining information in one index, using all the information in different displays, obtaining better neurophysiologic measures as we know more on neuroscience of anesthesia, or maybe even we can think about introducing imaging techniques in anesthesia. That's something that we will be waiting for, and we need to see what's going on in the near future. Thank you so much.